Okay, so just some reminders about presentations, especially when you're not going. Make sure that you give the person speaking your undivided attention. So all phones need to be put on silent and or turned off and put away. Phones should not come out at all during presentations, or else I'll take points away from you. So make sure that you give the person speaking your honest and fair attention so that they will do the same for you. Don't want to be a distraction to the speaker and potentially cost them some nervous points when they start focusing on you instead of on what they're saying. Okay, you good?
Are ready?
We're ready.
Alright, so I did my case study on navicular stress fracture with surgical intervention. I'm going to start with some basic anatomy. So the foot is made up of bone, flexible joints, muscles, and soft tissue. These structures give the foot the ability to support weight and distribute it evenly, which gives us the ability to stand upright, walk, run, and jump. Some basic structures of the navicular bone. It's one of the 7 partial bones. It's located medially on the medial side of the foot. It articulates proximally with the talus and distally with the 3 cuneiform bones, and laterally with the cuboid. In this picture, you can see how the navicular bone sits in between the talus and the cuneiforms, and then the cuboid on the other side. This is one of the reasons that stress fractures are common, because a lot of stress is put on that bone because it has nowhere to go when pressure is applied onto it, which causes stress fracture. For my case study, I focused on a 20-year-old male who is a collegiate athlete. He throws javelin. His injury was to his left foot, which was his planting foot when he threw the javelin. He had no past history of any foot injuries. He denied changing any shoe wear or anything during the season, getting ready for outdoor season. His symptoms presented tendinitis, so there was no swelling or discoloration, and there was no specific point tenderness. It was general foot pain, so it was really hard for them to diagnose. For 4 weeks they treated it like tibialis anterior tendinitis, and with no improvement they referred him in to see the team doctor. The team doctor had them do a CT scan, and it showed a distal stress fracture of the navicular bone. The team doctor decided to refer him in to an orthopedic surgeon. The surgeon had them do a bone scan to make sure that the CT didn't miss anything, and they noticed that the fracture was almost completely through the bone. So the surgeon suggested that they do surgery over immobilization based on his high performance in athletics and the healing process, because with immobilization there's always a chance the bone doesn't heal right and that there's a non-union. The surgical approach they chose was a transverse approach to the navicular bone. The one incision is made between the tibialis anterior and the flexor italicus longus, and the red right in here shows where the incision would be made, and then they cut a gutter down to the bone, which is just basically they dissect all the muscle and stuff away so they can see the bone. And then once the bone is exposed, they place 2 clamps through stab incisions on either side of the bone, and the clamps are used to press the bone back together. And then they use what's called a K-wire. So they drilled 2 holes into the bone and insert 2 wires to guide where the screws will go. The screws fix the bone into place. After surgery, the athlete was placed in a cast for 6 weeks and was non-weight bearing for that time. After the 6 weeks, the athlete was placed in a walking boot for 3 weeks, and he was able to take the walking boot off when he was doing rehabilitation, or if he was just sitting around at home, or to go to sleep. The rehabilitation goals were to focus primarily on the lower extremity, but also take a holistic approach. They didn't want to leave any area out, so there was no deficit when the athlete returned to play. The goal was to return him to full participation as soon as possible. The athlete's goal was to be back by the following track season. And during the rehabilitation process, a variety of modalities were used to treat the athlete. So for swelling and pain, we used stim and ice, and then for scar tissue, Graston was used to help break it up. Protocol outline. There were many different protocols put in place to bring the athlete back. These consisted of range of motion, lower extremity strengthening, lower extremity stretching, pool protocol, upper extremity strengthening, core, speed and agility, plyometrics, and throwing progression. Following the use of a walking boot and crutches, and he also was on pain medication, we started initial range of motion, which focused on plantar flexion, dorsiflexion, eversion, and inversion. They wanted to keep it very linear at first, but as soon as he started to show improvements in those areas, ankle circles were added. So on the BAPS board was started. PNF stretching was also used to help kind of stretch the muscles of the foot because they've been so immobilized for so long. And joint modes were also used to help bring back range of motion. Lower extremity strengthening and stretching. The primary goal was to have equal strength in both feet. This was done using TheraBands at first, but as the athlete progressed, he was able to start lifting for his lower extremity. And then stretching was added to maintain flexibility and improve it after surgery, but it wasn't a primary goal. He was advised to do stretching on his own time, so he wasn't like wasting time that he could be improving in the PC. The pool protocol was put into place. The athlete started off with deep water running and then moved to plyometric exercises. The pool was used because we can kind of adjust how much stress is being put on the bone by how exposed the athlete is in water. So the deeper he is, the less stress put on, and then we could bring him to shallower levels and put more stress on the bone. The upper extremity and core exercises, the goal is to maintain strength in the upper extremity and throughout the whole kinetic chain. Based on the athlete's sport, the core strengthening program was also added to the rehabilitation process. With throwing the javelin, it's really important for them to have good core strength because that's where most of their power comes from. And then speed and agility exercises were also added. They're actually really important with the javelin approach. The athlete wanted to keep his approach pretty similar to what he had, and the smoother his crossover is when he's throwing, the more power he can generate through his body. And with the agility exercises, we really focus on trunk rotation because at the end of the throw, he has to rotate his whole trunk to generate the power through the javelin. We also use speed and agility as a functional test for plyometric exercises. Plyometrics were added, and a few functional tests he had to pass before they were actually started was the athlete was first assessed on his jumping form for any various or valgus angles on takeoff and landing or any imbalances he had when landing. There were no abnormalities, and the athlete was able to progress as normal through the plyometric exercises. And then the throwing progression started with standing approaches, so he wasn't putting any stress on the bone, but he was still able to throw and still get back into throwing before he was able to do full approaches. The athlete had to pass a number of functional tests before he was actually allowed to do full approaches because it was his planting foot, and to put that much stress on, we didn't want to hurt the foot again and have to go back on the season. So he had to do his speed and agility with no pain or any hesitation, and the plyometric drills had to be done at a high intensity with no pain. The return to play was allowed, but he had to be under so close supervision of the coaching staff and the athletic training staff. There was a note that he was the kind of athlete, if he got the green light, he was just gonna go for it, and it was noted. So he was under really close supervision because we didn't want him to injure himself further or mess up the surgery. And the athletic training staff and the coaches met, and they decided that he had to prove in practice that he could throw at a competition level before he could compete in the meet. And He actually didn't compete in the first 2 meets because he himself didn't feel like ready and confident enough to do that. He decided to hold off and keep working before he competed, but he did make a full return to play for the outdoor season. He wasn't allowed to compete in the indoor season because of rehabilitation. In conclusion, the navicular bone or navicular stress fracture is a fracture to the navicular bone. This specific case was treated with surgical intervention, and the method used was fixation with screws. The return to play progression started very simple with range of motion, but completed with full return to play. This case study brings awareness to stress fractures and the difficulty in diagnosing it and how to approach a correct treatment outcome. That's it. Any questions?
Yes.
Okay.
With regards to the plyometric exercises, you said landing and jumping, looking at vagus varus alignment. You also said imbalances on landing. What do you mean by imbalances?
Like if he was landing and like favoring the other foot, or like was not putting like the same amount of weight when he was landing, is what I'm
With the throwing progression, you talked about him throwing at a competition level.
yeah.
I'm just curious what you meant by that versus practice.
For like the competition level, he was throwing for distance because usually in practice they don't really throw for distance. So he had to throw for distance and show that he could compete just as well as he was before the injury, before they wanted him to compete in a meet.
So he had to hit a distance mark before he could
Yeah.
compete. Did you use joint moves at all with range of motion?
Yes.
Which moves?
I don't know.
Okay. What was the total timeline from injury to full return to play?
6 months.
Anybody else? Okay, thanks.
Who's on